Good morning, everybody. I think my audio is coming through okay. So I'm gonna set myself a timer because I was told that I have 40 plus 20 for questions. Very much looking forward to this conversation with you. I'm gonna just take a few minutes to get ourselves situated in what we're going to do today. I don't like podiums and I don't like standing behind them. This one's transparent, so that's great. But as an educator, I like to move around and have a little bit of space in which to do that. Basically, the chair and the edge. I'm gonna just move a little bit and be comfortable within the space. I want to spend time today chatting with you about my personal and professional journey through systemic ableism in biomedical research and health sciences. And I come at this as a scientist with a disability. And I come at this as someone who has acted as a caregiver and support person. Obviously a caregiver and support person with disabilities for a family member with disabilities. And so how we navigate the space, I think, becomes a very interesting conversation when we start talking about patient engagement and research and how we do patient engagement and research. In other spaces, patient is not the word that's used, partner is the word that's used. And so sometimes I will actually use the term partner. Some folks try to have their cake and eat it too and say patient partner. And that will turn PiPER into PiPER, which, I mean, PiPER is a much nicer acronym. But both patient and partner start with the letter P. So we're gonna have a chat for 40 minutes or so. Happy Science Literacy Week. That's the first thing I want to say. This is Science Literacy Week, and so I would be remiss if I didn't actually say that. Also, every time you see one of these deep purple slides on the screen with the IDEA-STEM watermark, you'll find a QR code. You should be able to flash that QR code. And you can then access IDEA-STEM's contact information for its website, its LinkedIn profile, and so on. Check us out, follow us if you like what I have to say. If you don't like what I have to say, then you'll be rid of me in an hour. So first things first, science is a universal human right. December 10th of last year, the International Science Council issued a declaration that access to participating in and benefiting from science, technology, engineering, and mathematics, inclusive of all the health pieces, was a fundamental human right. That meant everybody on the planet, alive and still to come, should have the fundamental right to participate in and benefit from STEM. And that includes patient engagement research or partner engagement research. If you want to read the declaration, the QR code on the left will take you to the declaration on the ISC website. If you want to read the editorial, I was invited to write about it, which actually focused a lot on education. I had so many things to say on education and then on employment and then on healthcare, and the writer they assigned to me cut me off after I was done talking about education, so I still have to say the things about employment and healthcare. But if you want to read the editorial, please feel free. The QR code is on the right of the screen. I'm looking at the screens in front of me. You're looking at the screen above me, but they show the same thing. So IDEA-STEM as an organization positively contributes to a world in which participating in and benefiting from employment, education, and healthcare, particularly through STEM, is a universal human right grounded in disability justice and inclusive of persons with disabilities. I was the first person in the world who was identified as congenitally blind, who was doing a PhD in genetics, and my fundamental question is, well, frankly, why the hell is that? It didn't make sense to me at the time, and it, to some degree it still doesn't make sense, but I understand it a lot better now than I did before. And in understanding it, I and my co-founder have built IDEA-STEM to actually help the world understand it as well and help the world do something about it. And we envision systems that are transformed by the leadership, knowledge, and creativity of disabled, neurodivergent, mad, and chronically ill persons. I actually realized that I don't have an acknowledgement slide identifying the team, and I will sprinkle their names in at the end if we have some time to make sure that I do recognize the wonderful people that I work with and my equally wonderful co-founder. So what do we do as an organization? We care about science, we care about strategy, and we care about knowledge. We care about inclusive science done inclusively, done by inclusive teams and taught in inclusive ways. We care about organizational strategies around accessibility and inclusion, hence this conversation we're having today. We care about teaching people how to do that through learning and development approaches and coaching approaches, and we care about generating knowledge and applying that knowledge. We are scientists, so we do science, and the science that we do is intended to influence policy and influence practice in this country and around the world. So here's an important question. On screen is an iceberg in Antarctic waters under a leaden gray sky. Would you like to live there? Or would you like to live on the tropical beach? Now, just an audio check here. How many want to live on the iceberg? Don't raise your hands, I can't see them. Audio check. How many want to live on the iceberg? Okay, how many want to live on the tropical beach? Invariably in every room. That's always going to be the answer. I have yet to meet a room that has thunderous applause for the iceberg. But also invariably there's always somebody. So there's a metaphor there. We'll come back to it. I want to introduce myself to you in a way that that Kathy didn't. Kathy kind of used a shortened version of my biography, but that's kind of boring. So I'm going to tell you my favorite color is blue. I'm a science fiction fan. Live long and prosper, everybody. Not let the force be with you, but live long and prosper. I love to cook. I love to read. I absolutely love to spend time with my 3-year-old. My second language is Spanish. Hablo español un poco. I can count to 10 in 5 languages. I love warm beaches, not cold ones. The sound of oceans I find very soothing. I love Cape Spear. You can go there and you can listen to the pounding of the Atlantic surf all day long. I'm a son, a brother, a cousin, a father, a friend, a husband, a dad, a scientist, an educator, a researcher. I'm cis male, neurodivergent. I live with a disability. I was born blind. I live with low vision. I was born in Guyana, South America. I'm South Asian, Indo-Caribbean, first generation settler, newcomer. I had corrective surgery to remove my complete and total cataracts at the age of about 16 months. So that means that I now live with low vision, but I also have neurological vision loss associated with the physiological vision loss. And I introduce myself this way. Number one, it's a lot more interesting than what I do, but also because we're fully dimensional persons, each with our many facets, and we're not only our identities, we're not all identical, we're not only our lived experience with our disabilities or with our engagement with healthcare. We are people. And that personhood is at the core of doing patient engagement research right. When I self-identify, I often get tagged as, well, you're your disability, you're blind. That's the end of the conversation, right? I've come into my identity as autistic much more recently, and so a lot of people will say, well, you're the blind scientist, and that's the end of it. But there's many blind scientists, at least one other one in the room. Hi, Stuart. And so the interesting thing is that I happen to have been the first one, right? And you know, that moniker follows me until I die, pretty much, unfortunately. But that's not who I am. Who I am is all these other things, right? I'll get tagged as disability first, I'll get tagged as disability only, but that minimizes my intersecting identities. It also minimizes my personhood, and that is a key message. If you take nothing else from everything I say, take that. So this is the I am my disability thing. So the circle represents moi, and all I am is the blind neurodivergent guy. That's boring. Also not true. But then what we can do is we can actually talk about all of the elements of my lived experience, and I took basically everything I used to introduce myself and I put it in a bicycle wheel. You don't have to read what's on the wheel. Nobody is ever going to read what's on the wheel. But the fact is the wheel is there, and at the center of the wheel I put my disability, my lived experience. But that's also not really how I view the world. So that might be disability first, but that's not me. What's me is putting me at the center of that lived experience, and all of the things on the wheel, including my lived experience with blindness and my autism, are part of who I am. And this is the core of the personhood issue, right? Because we contain multitudes. We're people. we're multidimensional people, and we're people who like doing things and participating in things just like anybody else does. So my positionality comes at this conversation through that lens of caregiver and parent and educator and someone who does accessibility in STEM and healthcare, who founded the field in Canada, what's now 15 odd years ago, who is a healthcare researcher, and who is also an inclusion, diversity, equity, and accessibility professional. That happens to be a unique combination of things, and for better or for worse, you're gonna be entertained by that for the next 29 minutes. So I don't want you to read the slide, and I'm not going to tell you about all of it, but this is effectively a timeline that highlights my experience as a caregiver, a spouse, and a parent. The person I was caregiving for is actually my spouse, and it's not my story to tell. Our connection with the oncology and healthcare systems, it's actually her story to tell. If we were on stage together, we would tell it, and it'd be quite funny. But we went from couple to treatment to engagement, marriage, COVID, house, baby, and now three-year-old preschooler, all in the last 7 years, right? So that's a lot going on for any one human being, right? But that lived experience as a caregiver, a spouse, and a parent influences how I think about healthcare research today as a researcher. Often what gets forgotten about is this intersection between being a caregiver, a spouse, and a parent, and being a healthcare researcher. I can be a subject matter expert as well as somebody with lived experience. My healthcare research journey is much longer than that. It's gone from basic medical sciences into translational, to clinical, to population data science and diagnostics, to public health research, to organizational systems research on accessibility, all of that in the last 20 years. I've been engaged in accessibility in STEM and healthcare for almost as long, frankly, and started by being interested in the experience of students with disabilities in grad school, then specifically students with disabilities in STEM, then the working environment, then the healthcare environment, and now this is what I do for a living. And I'm also an IDEA research and professional specialist. So I've been a chief accessibility officer, I've been on accessibility committees, I've run IDEA teams, and in fact, I tend to preferentially run teams that are comprised almost entirely of persons with lived experience. And one of my previous bosses once said to me, you deliberately find people that nobody else wants, don't you? And I said, what's wrong with that? And she said, nothing, because somehow you managed to make it work. And so I do this for a living, right? And the thing is, everything intersects. And so I put that intersectional bubble diagram back on. I took all of those lovely little timeline charts and I shrunk them down so nobody could read anything. And I put them all here to demonstrate the volume of that intersectional experience. All of that to say to you, I kind of sort of know what I'm talking about, maybe not really. And so what have I learned from all of that? I've learned that there's this tension that I have as being somebody who has lived experience from intersecting and interacting with the healthcare system, while at the same time being someone who works within the healthcare system. And when I think about interacting with healthcare, some of the things that I've picked up, it's become quite clear to me that in the healthcare space, we tend to treat the condition, we don't tend to treat the person. We tend to look for common causes. The number of times that my wife's hearing loss was mistakenly associated with her brain tumor, I cannot count. But she lived with hearing loss from the age of 3, and she lived with a brain tumor from the age of 29. So one didn't cause the other, but they existed in the same person. The whole notion of watch and wait, the idea that in the healthcare space, as a patient partner, we can say to someone, you know what, we're not ready to do something. Let's just sit, take a pause, figure out what happens. And we think about that physiologically, but this is also Mental Health Awareness Week. Friday is World Mental Health Day. We don't think about the mental health side of it. We don't think about the consequences of the casual, let's just sit and wait for a little bit, right? The other lovely quotation that I've heard many times from physicians, and I've heard it myself, given the relative stability of my eye condition, is I can't do anything for you. And what they really mean is, maybe you need to go to some other part of the healthcare system and interact with some other part of the healthcare system and work with some other part of the healthcare system. But what they say is, I can't do anything for you. And how humans internalize the words, I can't do anything for you, is another one of these issues associated with mental health that I don't think often gets thought about. In traditional healthcare and healthcare research paradigms, knowledge flows upward. It flows from us, the plexers, all the way up to the principal investigator at the top of the grant. It doesn't flow downward, outward, inward. It flows upward. So there's a one-way directionality, and associated with that is a one-way power dynamic. The last piece of this is the lovely way that we interpret the word accessible in the context of healthcare. Accessible means many, many, many things. The English language is a wonderful language. Words are synonyms and homonyms for other things. And accessible has at least 4 or 5 different meanings. The meaning that matters for persons with disabilities is, can I participate in the thing? Can I do the thing? The way it gets interpreted is, okay, here's a wheelchair accessible hotel room, right? Or, yeah, you can actually access the file because it's a PDF. It's available on your phone. I don't care it's a PDF. I have to be able to read the PDF. Those are not the same thing. So how we think about accessibility is filtered through this lens of, it doesn't refer to persons with disabilities, it refers to being able to read a PDF, or it refers to a hotel room where you can roll into the shower. Working within healthcare, I've learned that there is a pyramid of power within healthcare research, that trainees are at the bottom, but also at the bottom are those of us with lived experience. I've also learned that the traditional paradigm, that I'm not saying this is what PiPER does, I'm in fact saying the opposite, but the traditional paradigm, the paradigm that we ought to push and evolve, the thing that we're working to shift, is that professional experience rules over lived and living experience. There's a myth of perfection, that you cannot be a healthcare researcher or a healthcare provider unless you are not a person with lived experience. Experts solve things, and there's a specific definition of expert. Right? And I said before, patient and partner are the same thing, and in the traditional paradigm, patients are not partners, right? And engagement is new. Disability is the largest minority group in Canada, and 27% of Canadians identifying age 15 to 64 are persons with disabilities, according to the Canadian Survey on Disability 2022. That does not include folks who identify as living with a health condition that is technically disabling. The thing is that the way that we ask about disability, we ask about it in terms of a social identity, but not everyone recognizes as living with a social identity. And so we have all sorts of folks in the world, all sorts of folks in the country who won't answer yes to the questions on the Canadian Survey with the Canadian Survey on Disability, but who would answer yes to the question, do you have diabetes, right? Or do you have a heart condition, right? And so that's a different conversation, but those folks, because something like diabetes is a disabling condition, something like a concussion is a disabling condition, right? And so whether folks identify as living with disabilities or not, those folks still benefit from accessibility in the world. The problem is that when we talk about it, we don't count that group of human beings. 200 years ago, 250 years ago, we talked about disability in the world as an affliction. Affliction's a fun term. It basically means something that you have to carry because it's been given to you by whichever deity you believe in, and because it's been given to you by a deity that you believe in, you kind of just have to live with it. Right? So we talked about disability as an affliction up until the publication of On the Origin of Species by Charles Darwin. And then as evolutionary theory got taken up by society at large, we started to think about, we being Western society, I mean, and that's not me, so I'm going to stop saying we. Western society started to think about life as a game, life as a competition, because evolution's a competition. That's how it was popularized. And so we started to talk about handicap, because you are handicapped in the game of life. That's where the term handicap actually comes from for persons with disabilities. In the middle of the 20th century, we started to get away from that. We started to use the term disabled. Disabled is another fun term. I took Greek and Latin for scientific terminology in first year university. That was a lovely course. I got to swallow a dictionary. It was fun. Dis, Greek prefix meaning not. Habile, Greek word meaning to be capable, to be handy. So disability literally means to not be capable, to not be handy. Any other identity term in the inclusion, diversity, equity, accessibility space, you think about gender, you think about race, you think about culture, you think about ethnicity, you think about language, you think about sexual orientation, you think about whatever you want to think about. All of those terms are not pathological, not technically, right? Disability by definition is a pathological term. It's the only one that is like that, right? And so no wonder people don't necessarily want to associate with it. In the 80s, 90s, and aughts and tens, we started to come up with different things like differently abled and diffable and diversible and diversability. And those are great. The problem is that they don't foster an acknowledgement of the oppression that goes with the word disability. And so the disability community, the goal is to reclaim the word so that, yes, it's a pathological term, but acknowledging it and owning it means you can subvert and convert the narrative around it, right? In the neurodiversity space, we talk about neurotypes as part of human neural variation, right? It's a phenotypic thing in genetics to use the term. Perhaps one day we'll get there with respect to all other disabilities. Perhaps we won't, right? But we can't forget the history. We have to recognize that whatever word we use, the history goes along with it. And so how do we think about disability in the biomedical sciences space and in healthcare? We think about it as this sort of tension between, is it a health outcome and is it a demographic or social identity? And the problem is it's actually a little bit of both, right? So it's more of an identity or a demographic for somebody who was born with a lived experience like I was, but it's more of a health outcome for somebody who, for example, is 65 years old, experiencing age-related macular degeneration, and the only thing they want is their driver's license back. No offense to anyone who's wanted their driver's license back. Funny story, my father had cataract surgery when he was 75, and he couldn't drive for a couple of months, and he said, I feel like I'm in jail. And I said to him, Dad, I was born with cataracts. This was when I was 35. I said, I've not driven for 35 years of my entire life. Do you think I'm in jail? Dad, being Indo-Caribbean from the generation that he was from, said, yes, but you're used to it. Right? His point being he wasn't. Right? And that's actually the distinction that we don't often take into our awareness, because the lived experience of disability is so very diverse, right? And the reality of that lived experience is quite broad. We're thinking about, it's not something that is truly monolithic. We talk about disability as if it were monolithic, and in reality, it's very personal. There's 8 million persons with disabilities in Canada, and there's 8 million stories of disability in Canada, and 8 million intersections with the healthcare system and with health research. We've got to talk about, how old are you when you identify as living with a disability? Were you born with that lived experience? Did you come into it early in life? Did you come into it later in life? We have to talk about the context of, was it a permanent disability? Is it a temporary disability? Is it episodic? Is it progressive? Is it situational? We've got to talk about whether it's an apparent disability or a non-apparent disability, put another way, visible or invisible, hidden or not hidden. We tend to assume that physical and sensory disabilities are apparent and everything else is not apparent, but that's actually not the reality of the situation. The reality of the situation is that an apparent disability is only apparent when somebody's actually using an assistive aid or device or piece of technology in a manner that helps them carry out daily tasks in a way that is obvious to an observer. Now, the thing is that my iPhone is a piece of assistive technology. The problem is that everyone goes around downtown Toronto with their head buried in their phone, right? And so me following the little blue dot to get where I'm needing to go, if I have to use it, because I know downtown Toronto really well, and I often don't, but me following the little blue dot, I'm using my phone as an assistive technology. Everyone else is surfing the web, right? but it's not obvious that I'm using it as a piece of assistive technology. And so if my cane were not out, right, then it doesn't look like I'm using a piece of assistive technology. So nobody would actually know that I live with low vision. You would all know because I told you, right? So we imagine then a disability framework that's very different from the one that we actually think about. We imagine a framework where one's lived experience is modulated by how one interacts with the world, by how old we are when we come into our lived experience, by the context that we have, by the functional impact of that lived experience, by our use of assistive devices or aids or technology, by the environment that we're in. That means that I, who have very poor contrast vision, would rather use my cane at night, but I don't have to use my cane in this room unless I stupidly get close enough to the edge that Matt so very kindly marked for me. Right? So how does this play out then in the context of personhood and power dynamics in research? And I'm going to introduce to you a little pyramid. So this is the traditional power dynamics in biomedical and health sciences. At the top is the physician scientist, the owner of the grant. Underneath that's the clinical staff, then the lab staff, then the admin staff, then the patient and caregiver. Does that sound familiar to anybody? Maybe, right? In a single team, you've got the PI, then the postdoc, then the doctoral student, the master's student, the undergrad. In a grant, you've got the nominated principal applicant, the co-principal investigators, the co-applicants, the collaborators, and then the trainees. On translational teams, you have clinicians at the top, then scientists, then the clinical staff, then the scientific staff, and then the trainees again. And in research, the folks who generate knowledge are the ones who are at the center of the power in this pyramid, and the ones who are the research participants are not, except we're the research participants, we're the ones contributing that knowledge. And so those folks who are generating it, where are they getting it from? Right? And so the power flows toward the top of these sort of pyramidal structures, right? And in science, we do a lot of reductionism. We try to simplify things. We do a lot of compartmentalization. We try to group things into bins and buckets. And so our lived experience, as nuanced and as diverse and as varied as it might be, gets put in a box and gets segregated as different from the next person's box. Right? And this is how we get distilled into lines on a scientific paper. Having written scientific papers, I know this to be true. So there is a hierarchy of personhood in the world, and let's come back to that wonderful blue pyramid of mine. By the way, I failed grade 8 art, so I don't do well with PowerPoint thingies. So if I'm trying to draw something with my voice that you're not imagining as I'm drawing it, that's my bad. But if you're looking at something and it doesn't make sense to you, that's because I failed art. So in this pyramid, and we think about colonialism, and we think about how the world has evolved through the lens of who the Western Europeans colonized, and where they colonized, and what they did, then we live in a world where somebody at the top of the pyramid has the most power, they're the most human. Somebody at the bottom of the pyramid has the least amount of power, they're the least human. And so you can take that framework and you can apply it to skin color. White at the top, black at the bottom. You can apply it to labor. Colonial landowners at the top, indentured laborers and slaves at the bottom. You can apply it to socioeconomic status, rich at the top, poor at the bottom. You can apply it to disability broadly, so non-disabled at the top, disabled at the bottom. And believe it or not, you can also apply it intra to disability groups, because there's the hierarchy of disabilities in terms of who can mask, who can, quote unquote, look like the non-disabled population more easily, and they tend to be at the top, and the rest of us are at the bottom, right? And so those with the most power, in terms of the social stratification, are at the top of the pyramid. The ones with the least power at the bottom of the pyramid, but then the ones with the most power have the least incentive to change, and that happens to be the world that we live in. And the ones with the least power have the greatest incentive to change, and that also reflects the world that we live in. The other thing I think is really important to think about is when we talk about accessibility in this space, we talk about disability, we come at it through a very person-centered lens, and there's a lot of history behind that I don't have too much time to get into. But the reality of it is that, that when we think about the way we interact with the disability lived experience, we interact with it through a lens that is very medical, through a lens that's very confidential and health information, and we also interact with it through a lens that effectively says that we're putting the person with the disability at the center of whatever it is they need to be at the center of. And so we're going to address things for that one body, and we're not going to try to correct what the system does, right? Which is a really interesting challenge. And that's how we encounter barriers, and that's how we ask for help, and that's how we figure out how we solution find in the context of what those barriers are. But we solution find as individuals, we don't solution find collectively, right? And what we fail to realize is that yes, there's intrinsic factors that are person-centered that might relate to that lived experience, but there's also extrinsic factors that are systemic and environmental that contribute to that lived experience because person interacts with environment, right? And so let's reconceive the issue of barrier then, and let's think about the iceberg that I talked with you about in the very beginning. 90% of that iceberg is underneath water, 10% of the iceberg is above water. The 10% that's above water is the personal reflection of a barrier. The 90% that's below water is that systemic barrier itself, right? And so that systemic barrier will look different for different people on different points of the iceberg, but it's the same barrier. For example, if I can't read a consent form, then the barrier is that documents are routinely created in inaccessible formats. The barrier isn't Mahadeo can't read the consent form. The barrier is the document's not made properly, right? If I need an oral interpreter or an ASL interpreter or a language interpreter, it's because meetings are held in the dominant language. It's not because I can't communicate in the dominant language. So it involves a reframing, right, of how we think about barriers. Healthcare works in the context of diagnose, treat, prevent. I once listened to Alan Bernstein when he was president of the CIHR, and he said something that really resonated. He said 85% of lung cancers could be prevented with a massive public health campaign against smoking. Apologies to anyone in the room who smokes. But we don't do that because we invest in the EGFR inhibitors for hundreds of millions and billions of dollars because that's a cottage industry. It's very lucrative. There's money there. There's no money in preventing lung cancer. And that is not just the way we talk about healthcare, that is also the way we talk about accessibility because we identify, remove, and prevent barriers the same way we treat and prevent diseases. We focus on the treatment first and the prevention second. Barriers come from ableism. And so let's talk about that for a moment. Ableism is the centering of having ability in a person's feelings, thinking, or behavior. So a person must be able to do something in order to achieve a goal. And that's ableism, right? To get a PhD, I have to look down the eyepiece of a microscope. That's ableism. To do fish, fluorescence in situ hybridization, I have to look down the eyepiece of a microscope. That's ableism. But saying, Mahadeo, you can't do that because you're blind, that's overt discrimination. That's disableism. Now, it sounds like the same thing, but in reality, they're actually two sides of the same coin, right? So ableism and disableism exist in tension. Nobody is going to admit to being overtly disablest. Nobody's going to admit to being covertly ableist either, but a lot of us are, and it's much harder to recognize, right? Disableism is overt, ableism is covert. And in the context of the biomedical and health sciences, we think about what we do within the research space here, and we recognize this space is fundamentally ableist because it's all about how we do the work and what the work is supposed to be and how we need certain abilities in order to do the work. And then we contradistinct that with people who can't do the work. I'm going to talk to you about two things for a moment very briefly. One of them is this question of does the destination matter more than the journey? On the left of the slide are a series of curlicues and curves in one straight line that start in the same place and end in the same place. And the question goes like this: does it matter how we get to an outcome, or does it matter that we achieve the outcome? 74% of the adult population in Canada believes that outcomes matter over the journey it takes to get there. And for those of us who remember grade 11 physics, this has to do with distance versus displacement. But the good of this philosophy is outcomes matter over process is we want everyone to be able to succeed. But the seedy underbelly of it is, I don't care if it takes you 10 times as long to access a Microsoft Teams meeting because you're using the keyboard as it takes me because I'm using a mouse. The fact is you can get in. But if you and I start at the same place at the same time, you're going to get into that meeting faster than I can because it only takes you 5 mouse clicks versus 50 keyboard commands, right? And there's no removing that issue because it's a sequencing issue, it's a temporal issue, and we have to reimagine, right? I'm going to be always late for that 11 o'clock meeting that starts at 11 on the nose because I access it at 10:59 and can't get in until 11:01, right? My old boss was very funny. He said, if you're not early, you're late. And he would actually basically lock the doors to the meeting room for team meetings if you were 5 seconds beyond the start time. And so this is jokingly for him. But also how we think about fairness actually matters. 73% of adults in Canada think that fairness is equal treatment, equality, as opposed to equal opportunity for success, which is equity, right? And so the cartoon on the slide is the apple picking cartoon. So everyone has a box trying to pick apples, but only the tallest person can reach the apples because they're the tallest person. Because you want to calibrate for height, you give everybody different size boxes. That's the right-hand side of the image. So all of a sudden, everyone can pick the apple. Because whoever did the right-hand side of this cartoon, remembered the point was picking the apple. The point wasn't giving everybody a box. It doesn't matter that everybody has a box. It matters that they can pick the apple, right? We teach our children this from a very early age in playgrounds when we say everyone has to take a turn. And then we have to uncondition them when we think they're old enough to learn about equity. And we wonder why it doesn't actually work, and 3/4 of the population think that fairness is equal treatment. In small homogeneous communities, equity and equality are the same thing because equity collapses down, functionally speaking, into equality, right? Now, this is really where I think ableism actually comes from. And so when we talk about ableism, we've got personal ableism centered on the human being, we've got systemic ableism centered on policies, practices, and frameworks. And we make assumptions in this space. We make assumptions about who belongs. We make assumptions about how rules apply. We make assumptions about use cases in every situation we think about. These assumptions underpin how we develop policy, practice, guidance, frameworks, but they're not conscious. We don't make them consciously. And so the truism that I would actually offer you is the system is actually not broken. We've built the system a certain way. It's doing the exact thing it's supposed to do. The problem is that we don't want it to do that thing, or some of us don't want it to do that thing. I would imagine everyone in this room doesn't want it to do the thing it's actually supposed to do. So our mission, our job, is to change the system. It's not to fix the system, it is to replace the system with a better one. Come back to that iceberg. The freezing cold Antarctic water that nurtures that iceberg that is 90% below the water and 10% above, that is what represents the ableism, right? You warm the water, acknowledging climate change for a moment, which is a real thing. You warm the water, the iceberg melts, right? If you keep that water at 4 degrees Celsius, that iceberg's not going anywhere. And so we can take all of those systemic barriers that we were talking about before, and we can turn them into ableist assumptions. And so the barrier that says documents are routinely created in inaccessible formats, that means everyone has the same level of functional vision. That's the assumption. I see the same way you see. Well, I don't actually, but the assumption is that I do. Or meetings are held in the dominant language because everyone uses the dominant language in the same way without assistance, and that's also not true. And we all know that. But those are the assumptions that underpin the barriers. So how do we get from the iceberg to the tropical beach? Right? That's the key question. And I have about 4 minutes left for whoever's timekeeping for me. Recognizing ableism in ourselves is actually very hard. We really need to be self-reflective about it. We need to be self-critical about it. Recognizing it in somebody else is actually a lot easier. But we don't call it ableism. We're like, your attitude sucks. And in systems, policies, and practices, recognizing ableism is the hardest possible thing. I have made a career out of figuring out how to recognize ableism in systems, policies, and practices. First in graduate school because I bloody well had to, and now because apparently people think I'm so good at it, I get to do this sort of thing for a living, right? And at the end of the day, the fundamental way we do it is we ask the toddler question. Why? And we keep asking it until we get answers, or we keep asking it until we flummox people into not giving us answers anymore, right? How many of us, when confronted with a toddler who says, why is the sky blue? And they keep asking that and asking that and asking that and asking that, how many of us will get to the point where we say, just because? Sound familiar? Nobody agrees with me, right? Nobody wants to agree with me, but we've all done it. I swore I would never do it for my nephew. He's 23 now. And I swore when my daughter was born, I'd never do it for her, no matter how annoyed I might be about it. Now, when we think about ableism, we also think about not being ableist, the same way we think about not being racist, not being colonialist. But just as not being racist isn't a thing, you want to be anti-racist, you also want to be anti-ableist, right? I don't care if you're not ableist, because then you're a bystander, you're a passive observer, right? You're not doing anything. But if you're actively anti-ableist, then you're doing something. You're saying, wait a moment, that's a problem. Let's do something about it together. So we counter ableism through allyship, which is a whole separate conversation. And we counter ableism through universal design, inclusive design, equitable design. And as the saying goes, if you're not part of the solution, you are part of the problem. Universal design, for the record, is a set of environmental solutions designed to maximize inclusion of the greatest number of persons within fill in your blank: workplace environment, education environment, healthcare environment, research environment, what have you. The problem with the word universal is we interpret it much like we interpret the word accessible. In incorrect ways. We interpret universal to mean one size fits all, but it's actually not one size fits all. That's a common misperception. There are a number of models of universal design: physical, universal design of instruction, which is applicable to professional development and learning; universal design for learning, which is applicable to communication. A model that I came up with some colleagues, including my co-founder for IDEA-STEM 10 years ago, called the cultural UD model, which is applicable to policies and practices, and one for the universal design of workspaces that my previous team at CNIB and I evolved 5 years ago. And so when we think about universal design, we think about building out those solutions, we think about how do we actually create spaces that are fully accessible and fully inclusive. We want to think about, well, how do we apply universal design principles? We want to think about what are the things that physically actually need to be done within this space as a participant, as a researcher. How can we identify what we call essential requirements, right? We want to think about coaching trainees, sponsoring trainees, educating the next generation to do it right when the current generation struggles with it because we were taught to do it wrong. We want to reframe the conversation around accessibility, support, or accommodation. We want to get away from a reactive approach. We want to get away from a, what do you need? You got to tell me, to a, how do I anticipate? Right? We want to think about how we communicate in inclusive and equitable ways. And we want to think about how we, as persons who are doing this as a core part of what we do professionally, and who do it because we kind of have to do it from a lived and living experience perspective, we are educators within this space. I stand here and I have this conversation because at the end of the day, somebody in this room, I hope, will be inspired by what I said and will one day want to take up this mantle. And will one day want to take the world that I have helped create and make it better, right? And at the stage of the career that I'm at now, that's the cause that I spend the time giving my effort to. That's the reason I'm not home to take my daughter to daycare. That's the reason that she says to me every time I travel, "Daddy, please don't go." Right? That's hard when she says that. It's got to be worth it. This is worth it, and this is what I invite all of you to do with me. When we think about the way we talk about accessibility, we need to get away from the central circle there, which no one can read, which says accommodation. And we need to start thinking about accessibility as accessible by design. And once we've got that far, we can start thinking about being anti-ableist in order to be accessible by design. So we want to change that interaction with healthcare. We want to go from treating the condition to treating the person. We want to balance emotional well-being with physical risk. We want to acknowledge that the disability lived experience is not always related to other medical conditions. When we say, "I can't do anything else for you," we need to finish the damn sentence and say, "But others can." We need to acknowledge that knowledge flows outward from the patient and caregiver as much as it might flow upward, perhaps even more so. We need to think about accessibility by design, and we need to think about anti-ableist spaces and environments. From within healthcare, we need to recognize that everyone has different roles to play, and those roles are equal. There is no power dynamic there. We need to recognize that professional experience is valued equivalently to lived living experience. I chaired the Employment Technical Committee for Accessibility Standards Canada when we did the public review commentary and we looked at all the 900 comments that we got on the standard. There were a number of comments where we wrote in the tracking file that based on the lived, living, and professional experience of the committee, we did this, right? Lived, living, and professional experience, not just professional experience, not even just experience, but lived, living, and professional experience. We need to recognize that the Western ways of conceptualizing ability and disability are, I'm going to say, shackling us to perceptions and language and framing that perhaps we don't want. Definitely we don't want, right? You think about different ways of knowing and different ways of being, right? We're here to co-create solutions. We want co-research. We want full participation of community members and partners in co-research, not just patient engagement in a power dynamic. And we want the fact that community engagement should be embedded in the fabric of healthcare. I'm going to stop talking there. I ran a tiny bit over. We've got a lot of time for a conversation before the break. I hope that just because I'm the one between you and refreshments, you don't want to leave early, but we actually get a good chance to have a conversation. Happy to chat. Thank you so much for listening, and I look forward to spending as much of the day that I can with you.